Thanks very much indeed, John. Chairpersons, ladies and gentlemen, good afternoon. Delighted to be here. This is my title, and after all the erudite science that you've had through these brilliant talks earlier today, you're going to be stuck with a rather nuts and bolts talk from me, focusing really, I'm cherry-picking from the guidelines to give you the ABC of hypertension management. And I will stop occasionally just to say where I disagree. That's the political correctness. We don't have time in 20 minutes to go into that, but if anyone knows a company I haven't given a talk to, please give them my contact details. I can't afford to retire at the moment. Right. Key message, lowering blood pressure works in type 2 diabetes. We should therefore be doing it. And this is the effect of a 10 millimeter reduction in systolic, including 100,000 patients, and starting at the top with the things that really, really matter, down to those at the bottom, sorry, David, that perhaps don't matter quite so much. But you see here mortality, cardiovascular disease, coronary strokes, heart failure, renal failure, retinopathy, and albuminuria. And you see here these big effects down to a relatively small reduction in systolic blood pressure. So even if it's just albuminuria that floats your boat or frothers up your urine, whatever it may be, this works. It is worth lowering the blood pressure in type 2 diabetes. So what do the guidelines say about when to do that? And I should say here, I turn to the US guidelines, which is something I would not recommend by and large to do, but I'm doing it just because these are the most recent American guidelines, and you'll appreciate 2 years ago they declared unilateral Declaration of Independence and redefined hypertension for the world as 130/80. I'm delighted to say that no one else in the world has followed suit, and I think the rest of the world are right. Hypertension, till further notice, is 140/90 and above. But nevertheless, you see here for diabetes, just as for every other bit of or risk factor or subgroup, the threshold for intervention is 130/80, if you believe the Americans, but bear in mind they now diagnose hypertension as 130/80, and their thresholds are also 130/80. So it's a simple world in America, but I would suggest that you pay no attention to that. However, if we now turn to the most recent European guidance, which I think was a better document overall, that was 2018, and what you see here are the thresholds for intervention, and they're age stratified, systolics across the top, and as you see, apart from being 80 and above, I'm not quite sure, is that very elderly? It's older than me anyway, so they get 160/90, but everybody else is 140/90 as the threshold for intervening, and that's the case in diabetes. Okay, that's when we start. What are you going to use? And just as a generic approach, this is again from the most recent European guidelines, this idea of starting with 2 drugs is pretty much in, apart from the frail elderly or those with just a very slight increase in blood pressure, the recommendation is to start with combinations of drugs, and ideally, if you can get it and it's cost effective wherever you are, use a single pill combination. Now, what combinations you use, you'll appreciate the British use A plus C or A plus D, A being for RAS blocker, C for calcium channel blocker, D for diuretic. That's what the Europeans have recommended, and notice that's their standard regimen for diabetes as well. Now, I'm going to come back to that. And it must be said that the same sort of recommendation is made in the American guidelines and in the British guidelines to suggest that ACE and ARB should be given equivalents, considered as equally effective for the management of hypertension. There's a bit of a mistake here, because really what you should start with is dual combination at low dose. Step 2 is dual combination at full dose. Step 3 is triple combination, come back to that, and then you add in something else. But I'll come back to those issues later. What about the A plus C? So RAS blocker, ACE or ARB plus calcium channel blocker. There are really 2 trials that inform that recommendation. and that's ASCOT, which used an ACE inhibitor perindopril plus calcium channel blocker versus a beta blocker, atenolol, and low-dose thiazide. About a third of that population was diabetic, and the benefits seen associated with the A plus C, perindopril, amlodipine, were apparent diabetic or not. Accomplish, on the other hand, was mainly people with type 2 diabetes, and the ACE was benazepril, which we don't have here, of course, plus amlodipine versus benazepril plus low-dose thiazide. And I'll use those terms accurately, thiazide, not thiazide-like. So just to focus on the results of Accomplish, as I said, amlodipine, benazepril versus benazepril, low-dose thiazide, and despite getting almost identical blood pressure lowering, you see here the benefits, the primary outcome, cardiovascular cause, cardiovascular events, all the things you really care about favored the calcium channel blocker ACE inhibitor. So A plus C seemed to be better than A plus D, at least in this setting. Whether that would be the same had you used a thiazide-like diuretic is debatable. So we now turn to the A plus D. So RAS blocker plus diuretic. Here are the trials. You remember losartan plus thiazide versus atenolol plus thiazide. The losartan won. From a stroke point of view, the cardiovascular benefit was all driven by stroke. Actually, the atenolol was marginally better than the losartan in terms of coronary disease. Value was valsartan plus low-dose thiazide versus amlodipine plus low-dose thiazide. No difference. These three were post-stroke, very elderly, and in type 2 diabetes. And in these two, you didn't have to be hypertensive. But just to come back then to the A plus C, which is actually ACE plus diuretic against placebo in type 2 diabetes. And here you see the results. This is a combined primary outcome of the perindopril-indapamide combination. They used single pill indapamide perindopril, and there was a modest but significant benefit. The biggest driver of that cardiovascular outcome, incidentally, was cardiovascular mortality. That was the biggest contributor to the outcome. So the ACE diuretic gave 21% reduction in cardiovascular mortality. Biggest contributor to that outcome. So now let's come back to the question, should we be using ACE inhibitors or ARBs? And as I said, the latest American, the latest European, and NICE have given them equivalence. And here you see, I'll take you back to the previous NICE, 2011. The new one differs because before where they said A plus C, now they say or A plus D. But that asterisk reflected the fact you might consider diuretics under certain circumstances. But that was the algorithm. Younger people, when readings tend to be higher, RAS blocker. Older people of African Caribbean origins use a calcium channel blocker because the renins are lower, and they work better in that situation. So that was the basis for it, and that was the combo given. But notice the key for A is ACE inhibitor or low-cost ARB. We really appreciate that NICE were very financially oriented, and indeed still are. So it's a question of whether we do go for ACE or ARB. And in all fairness, NICE has got a very good excuse because they do a proper systematic review. And in that, the rules are, if you've got data where they're head-to-head, you have to count the head-to-head trial as the basis for your decision-making. And they did, and this is what it is. The only real head-to-head trial of morbidity mortality is on Target, where the patients, and these were high-risk patients, not necessarily hypertensive, although most were, about 2/3 were hypertensive, was telmisartan, which is a long-acting ARB, and I'll come back to that, versus ramipril, which is a relatively short-acting ACE, or versus the combination. Just as an aside, this was really the first time it's flagged up. Do not put two types of RAS blocker together because the hard renal endpoints give you a mess. But what you can see for the primary cardiovascular outcome, which was MI, stroke, or hospitalization for heart failure or cardiovascular death, classic sort of 4-point thing, there was no difference between the ACE and the ARB. So that's why NICE promoted it and said that they should be given equal balance in your care. Well, I'll come out of the closet and say, I don't believe that recommendation. I don't think it's right. I don't think it's what most of the data show. So how do I explain that? Well, it's the fact that this is a long-acting ARB and that's a short-acting ACE. And if you look in trial at the nocturnal blood pressures, those on telmisartan were 4 millimeters systolic lower at night. And you'll appreciate in a big number of people, if you've got a big lower blood pressure at night, you'd expect better cardiovascular events, and you didn't see it here. Now, we don't have time to go into this. It's a very lengthy argument, but if you look at the meta-analyses, which NICE aren't allowed to look at, and we look at hypertension, this is Van Vark's, just taking the trials after 2000, taking heart failure out of it, these are the impacts of the ACE inhibitors in the dark blobs and the ARBs in the pale blobs. Hypertension, ACE, ARB. In diabetes, Cochrane database, ACE, ARB. Coronary artery disease, ACE, ARB. High-risk patients, ACE, ARB. That's all-cause mortality. I find it very difficult to look at that and explain it away. But the Americans have done, and so have the European guidelines, and so has NICE. I think that's a mistake, but we're sticking with diabetes. It's not a new meta-analysis. This came out about 5 years ago. It's a second meta-analysis that had at least 55,000 diabetic patients involved, and it shows from the 23 ACE trials versus the 13 ARB trials what their relative effects were. All-cause mortality, these are all significant. All-cause mortality reduced 13%, no reduction with the ARBs. Cardiovascular mortality significant, increased in the ARBs. Cardiovascular events down 4, down 6, down 21, down 11. Heart failure was the only thing, both significant, that favored the ARBs against the ACE inhibitors. And interestingly, several of the heart failure guidelines do not promote ARBs over ACEs. Stroke reduction, some reduction here for ACEs, not significant, but not for the ARBs. So you've got these meta-analyses that's slightly worrisome. I'm now going to cherry pick, not because I think that's a good thing to do, but it's the one thing that really made me change my mind. And this was the roadmap trial, which had 4,500 patients with type 2 diabetes with no albuminuria, and some loon persuaded them that it would be a good idea to look at the impact of an ARB against placebo on the development of proteinuria. And that was the primary endpoint. But luckily, whilst they were at it, they looked at cardiovascular events, and the follow-up was 3.2 years. And they got a blood pressure reduction, not much, 3/2. You didn't necessarily have to be hypertensive, but that's the effect. If you look at the results, not surprisingly, you got a 23% reduction in new microalbuminuria. Fantastic. But once again, if you look, the disconnect between treating protein and cardiovascular events rose its ugly head yet again. And what you see here, all-cause mortality, these are small numbers, so I shouldn't even be showing this, but I'm going to. All-cause mortality up 70%. Cardiovascular death was increased 5-fold for those who had their blood pressure lowered with olmesartan as opposed to placebo. 5-fold. But these are tiny numbers. It's 15 versus 3. So maybe it's chance. It reminds me of the old ABCD thing where people suddenly panic because there appeared to be an increased MI with calcium channel blockers. But nevertheless, if you're interested in sudden and fatal death, that was 12 if you were on olmesartan and 1 if you were on placebo. That worried me, and it worried the New England Journal. It was there in the conclusions, but that seems to have been ignored. And if I turn to you and say, well, what trials have we got with ARBs? Cardiovascular trials, morbidity, mortality on ARBs. What have we got? That is what we've got. And I think it's worrying. Okay, so I think A stands for ACE inhibitor, long-acting ACE inhibitor. C, which calcium channel blocker should we use? I think it's easy, amlodipine. Why? Because it's the most effective agent we've got of any agent. It's got the longest duration of action. It's got all the trial evidence that you'll all appreciate, more so than any other CCB. We hear some of the other CCBs cause left ankle edema. That's true. They have no cardiovascular morbidity, mortality trial evidence, so I think we should stick with amlodipine. Which diuretic? Well, I had the job of looking through all the diuretic trials about 9 years ago, which was fairly boring. And it was the first to me that what was surprising was that there are no trials of truly low-dose thiazides. Two things there. What's a thiazide? And if you ask most doctors, you probably won't get the right answer, but it's easy. It says it on the tin. It says hydrochlorothiazide or benzoyl-flumothiazide. Chlorthalidone and indapamide are not thiazides. And the guidelines, if you read the guidelines, it's very confusing because they mix the terms. But thiazides, when I say thiazides, I mean those with thiazide in the name. And low dose, up to 25 milligrams of hydrochlorothiazide, which is 95% of thiazide scripts, is up to 25 hydrochlorothiazide. We have no trials of low-dose thiazides against placebo. The 3 trials, which is ANBP2, ASCOT and ACCOMPLISH, where low-dose thiazides have been used, compared with anything else, the low-dose thiazide was on the losing team on all 3 occasions. What we do have good evidence for in terms of diuretics is we've got higher dose thiazides, which most of us have stopped using for metabolic reasons, and 4 out of the 9 trials as of 2010 involved adding in potassium supplements. So what you've got is chlorthalidone and indapamide. Now, chlorthalidone is, I think, the strongest, longest-acting diuretic we've got, but it is diabetogenic. And you're going to have to finish up giving your patients potassium supplements in about 1 in 6 of the patients if you give them chlorthalidone at the doses that we used in the trials. It's sneaking in at 6.25 where there is no trial evidence of benefit. So this is what's been recommended, and this is really why NICE in 2011 said diuretics should be thiazide-like and not thiazides. That was the basis for the recommendation, which I think is pretty reasonable. Okay, A plus C plus D, and that's the next view of the guidelines recently. They all agree A plus C plus D. So RAS blocker plus calcium channel blocker plus a diuretic. As I said, they've got different names. There's thiazide-like or thiazide-type or thiazides. Some of them say thiazides, and they mean either thiazide-like or thiazide. But anyway, that's pretty much everyone agrees at this 3-drug level. What are you going to do after that if you're still not controlled? You are now, by definition, resistant. And we used to say in NICE, that's what we used to say, you're resistant, consider further diuretics. Well, in light of the Pathway 2 trial, based only on blood pressure, has to be said, that seems to be the favorite add-on drug, and I would recommend that. Low-dose spironolactone is a fantastic add-on drug as a 4th-line agent. Now, how low should we go? Well, I'm sticking with the European guidelines for the reasons I mentioned earlier. And in diabetes, you see here to 130, but not to less than 130, up to the age of 65. 65 to 80, get it to below 140, so in the 130s. And you see the diastolics are shown here. So up to the age of 65, get it to 130, and maybe in the 120s, but not below 120. The fear of the so-called J effect has crept into the guidelines, rightly or wrongly, and that's what they've shown here. So what else should we be doing apart from A plus C plus D plus spironolactone? Well, here's a slide I made earlier. You can see it needs updating with a few others, but it was to allude to the question of how far do you think the newer class of agents, the blood pressure bit, might be related. So if you look at systolic blood pressure across the trials, lixisenatide, which really didn't have any cardiovascular benefits, was no impact on the blood pressure. Liraglutide did have cardiovascular benefits, and there was a little reduction in systolic. Interestingly, the diastolic came up a little bit, which might tell us a little bit about mechanism. And then if you go SUSTAIN 6, the biggest blood pressure reductions across these trials anyway, and that at the time you might have said, well, that goes quite well with the lower stroke that was shown in SUSTAIN 6. Exenatide, bit of a benefit. And then when we go to Harmony, which gave good cardiovascular benefit, the blood pressure changes were minuscule. So if we just took a snapshot at these blood pressure changes and then tried to link it with the cardiovascular events in these GLP-1s, then you wouldn't really be persuaded from a mediation analysis point of view that that was likely to be a big driver. Having said that, if you get 4 millimeters systolic reduction, you do expect cardiovascular benefits, and particularly with stroke. So what else? We talked about the blood pressure lowering agents. What about the lipid lowering agents? And this is just to remind everybody what you get for a 1 millimole reduction in LDL cholesterol, stratified by diabetes in the smaller oblongs to the non-diabetics, and then the combination. And these are major coronary events. These are coronary revasc, stroke, and major vascular events. And what you see is the diabetics and non-diabetics have the same hazard ratios associated with them, which means the absolute benefit is much bigger. And to my mind, I think a statin is a no-brainer. I think most of the guidelines now suggest that if you're under 40, you need some other risk factor before you recommend a statin. And I'd say look around and find another risk factor and give them a statin. So in summary, I think blood pressure lowering is a pivotal way of preventing cardiovascular events in type 2 diabetes. I think the threshold we should start treating at 140/90. We should get to a target of 130/80, perhaps a little variation in the most elderly patients. I think the best evidence is for ACE inhibitors plus a calcium channel blocker given as a combination. And then if that's not enough, add in a thiazide-like diuretic. And for my money, that means indapamide, given the diabetogenicity of chlorthalidone. And then to that, I add spironolactone, which of course is wonderful at proteinuria as well. And then finally, I would add a statin. Thank you for your attention.